warm welcome to this summit on emotional health of mothers. We're very happy to have this very eminent panel of speakers. Today is a very interesting day. Just to give you a little bit of a background, White Swan Foundation is a Bangalore-based non-profit that works on knowledge dissemination on mental health. We'll come to the details of the organization a little bit later, but just to put into perspective why we're doing this discussion and why we thought that it was important to have a 360-degree conversation on the topic of maternal mental health and emotional health. We have been looking at mental health across communities for 6 years now. But in 2015, when we started to work with the Perinatal Clinic at NIMHANS and Dr. Prabha, who's also on today's panel, we understood that that maternal mental health is not just clinical, but has several other angles that very few of us know about. So during the course of our association with the Perinatal Clinic, we started to speak to mothers who told us that their stresses during and after pregnancy were social, and that they came from their environment, from their own personal issues, and so on. And so to look at the entire spectrum of what kind of issues mothers have, looking at the at what influence these their emotional health, we decided to have this conversation. And joining me on this panel to start with, we have Dr. Uma Ram, who's the Director and Consultant OBGYN at Sitapati Clinic in Chennai. Her areas of interest include fetal growth, multiple pregnancy, and fetoscopy. And she's very, very keenly interested in the in health awareness among women. We're also joined by Dr. Prabha Chandra, who is the head of psychiatry, the former head of psychiatry at NIMHANS, and is a leading perinatal psychiatrist, and is also the perinatal clinic at NIMHANS is her brainchild. Also with us is Dr.Ashlesha Bagadia, who's a perinatal psychiatrist and a family psychotherapist. Dr. Ashlesha has been instrumental in helping us put together this entire event, and I can confidently say that she's one of the most enthusiastic people I know as far as maternal mental health is concerned, and you'll hear from her shortly. She'll be doing a short workshop for us. Dr. Sonia Parial is a consultant psychiatrist and director at the Dhanvantri Hospital in Raipur in Chhattisgarh. She's also the co-chairperson of the Task Force of Perinatal Mental Health of the Indian Psychiatry Society. Dr. Sonia, of course, will be bringing us a very interesting angle of working in non-urban urban setting to some extent. We're also joined by Dr. Shaibya Saldanha, who's a OBGYN and also a lactation expert. Dr. Shaibya sees mothers right from when they are pregnant all the way up to when they're feeding the child. So she has a great level of interaction with mothers, and also is very, very keen on the mental health, the emotional health of mothers. She's known across Bangalore as the gynecologist who spends hours talking to her patients. So we're very happy to have Dr. Shaibya on. And last but not the least, we have Ashika Abraham Chitiappa, who has very, very kindly agreed to tell us about her experience with emotional health issues during her pregnancy with her second child. Ashika, in addition to being a fantastic mother, also runs an organization that helps busy mothers untangle their complexities and their daily life, and lessen the stress and workload, and create more time and space to focus on their own well-being. So we have a power-packed panel today, and so just sit back and listen. Towards the end of the session, we'll be taking questions from the audience, but during the course of the session as well, please feel free to just type in your questions in the chat box. We'll be taking your questions and feed them to the experts we have on board. During the course of the 2-hour session, we'll also be sending you a lot of content, a lot of information that White Swan Foundation has put together for mothers, for health experts, for this family support of women who are expecting. Please do take a look at this. You can also go onto our site and just type in the word motherhood, and you'll find several topics and several pieces of information. We also have an ebook that we'll be pinging in the chat window. So I won't go on for much long, and I think we can get started right away. But let's begin by introducing Dr. Uma Ram, who will be talking about how she sees mental health in her clinic. Dr. Uma, over to you.
Thank you very much. And I'm quite delighted to be part of this morning session. I think we are all very happy that conversations about maternal mental health are happening and gaining attention because it is an area where there has not been too much in terms of focus up until very recently, and there is a huge need for it. We all know that pregnancy and childbirth is a period of change, and there are a lot of changes that happen to a woman during this time, and these are layered with an expectation of how they think this pregnancy should be. And very often people assume that pregnancy is going to be a breeze, everybody is going to be happy, and it's all going to be a beautiful butterfly at the end of the whole process. But there are many changes that happen along the way, physically with the woman's body, that some of them are worried about or not happy about, emotionally, and of course, in the context of balancing their work and the changes that are happening during pregnancy. Some women adapt to these changes very easily. Some women struggle to come to terms with the changes that are happening. And unless we are cognizant of the fact that these issues are there, we can completely miss them. And there is good evidence that it's important to focus on emotional and mental well-being, as important as focusing on the physical problems that can happen during pregnancy. So any kind of issues that happen with women's moods, we tend to blame hormones. Of course, hormones do have a significant impact during pregnancy because there are a huge amount of hormonal changes that happen, especially in early pregnancy and in the immediate postpartum period. And this flux and change in the level of estrogen and progesterone is something that happens in every woman. But some women are more affected by these changes than others are. And so while the hormonal changes are there in the bottom or the crux of all the kind of emotional changes that can happen in pregnancy, these are layered by other things, as I said. So there could be tensions or issues in the family or the relationship which come to the forefront at this point. There can be work-related stresses. There can be past experiences of this woman or anxiety that she brings on because some friend or relative or cousin has shared a bad experience in pregnancy, which then affects her. And of course, if this pregnancy ends up having complications in it, then that adds on to the additional stresses that women face. So we can look at, I thought I'll share some of these stories that come out. So it's not uncommon for us to have, have women who come and tell us we are not able to sleep well, or I feel tired very often. And I'd like to share two instances. One where when I explored as to what actually was the problem, are you working, what is causing this stress? Then it came out that actually after marriage, this woman had been asked to stop work. She's not allowed any space for herself. And so she feels completely, restricted and controlled by the family environment, and has lost monetary independence as well. So this is something that we had to explore and then refer on, and also talk to her husband and try and sort out how she could, get back to doing things. The family actually thought they were being extremely helpful, but they kind of dictated what is the nature of work or course or whatever that she could do. So they came back and said, oh, we are not asking her to stop, but this is all that we want her to do. And we're doing it out of concern. So these may be, issues that we need to explore as well. Sometimes the anxiety is generated by the test that we offer. And classically, the test that causes most anxiety, in my opinion, is Down syndrome screening. It's something that we routinely offer, at least in the urban practice, very early on in pregnancy. And sometimes there is just a single note on the ultrasound which says nasal bone is not formed. Now, even if everything is fine and we tell them the risk for Downs is low risk, till this baby is born, and even afterwards, when I've had women who come back for the second pregnancy telling me, but doctor, in my first pregnancy, the nasal bone was not formed at 12 weeks. So even though they have seen and they now have a 3-year-old healthy baby, there is an impact of a so-called abnormal line on the scan report, which still generates anxiety, even though they know that this baby that they've had is perfectly normal. And this is something that we cannot discount, and we have to take that time to allay that anxiety. Now, this may not need medical intervention, but it certainly adds to anxiety. And then in terms of high-risk pregnancies, we see a lot of diabetic pregnancies. We see women who have pre-existing diabetes. Sometimes the families are not told about these problems. Sometimes they are aware. And it's very hard for us to understand why there is additional anxiety. Why can't people just take it as a matter of fact and get on with treatment? But we've had families where there are concerns raised by the family about why are there repeated tests needed? Why are repeated scans needed? There is a cost. And then this woman is made to feel guilty that she is diabetic, and that is why all this additional burden has been placed on the family for the test. And then, God forbid, there is a problem in that pregnancy that adds on, forgetting that that woman who is going through the pregnancy has the maximum to gain or lose from the process. There is this additional angle that falls on them. Of course, pregnancy loss, we all know, and this is an area where we recognize that there is going to be an emotional toll. But sometimes we underplay early pregnancy loss. If there is a very early miscarriage, say 6 weeks, 6.5 weeks, we tend to say, and it is factually correct, that your chance of a miscarriage in the subsequent pregnancy is not any higher than someone who's never miscarried before. But still, in the subsequent pregnancy, they need that additional reassurance. They may need to be seen more than once. And it becomes harder when there is a stillbirth that happens later. And there, the level with which we need to interact, because sometimes, even as the obstetrician, we may feel that have we missed something? There is grief, there is guilt, there is anger. And in those situations, particularly, it is useful to have additional support and electively or as a part of the system, include a mental health professional who can give guidance to this women and her family. Now, termination of pregnancy is another area where sometimes I've seen conflict. Couples may come requesting termination of pregnancy. On the face of it, it appears as if both are happy with the decision. But later on, you realize that actually there was a conflict. The woman would have preferred to continue the pregnancy. The husband or the family decides that this is not the right time, or vice versa. And if the woman chooses to terminate, but the husband actually wanted to continue, either situation, there is a conflict in this decision making, and this can impact future relationship. They will come back to you later saying that, I'm not able to take this away. I cannot come to terms with the fact that we were not in synchrony when we made the decision. But the decision is done, the process is over, but this conflict comes out later. And here, these are situations where, as an obstetrician, I am not completely trained or have the skill sets to deal with this situation, and therefore some kind of a reassurance and referral is needed. Fear of delivery is another thing that we often see. We've had women who say, we don't want to labor, we want a section. And it's worthwhile in this time to pause and have a conversation. And it is important to have this conversation with the woman alone and not have family members around, because you have to understand what is the fear. Is it just of pain? Sometimes in this particular situation, I realized that this woman actually had vaginismus, did not have that addressed, somebody just did an IUI and she became pregnant. And now she's petrified because she doesn't want to have vaginal exams. And the fear is not of the delivery, but of the fact that vaginal exams will happen and may happen by more than one individual at different locations. So in these kind of women, it is important to establish this, and we've actually handheld them, spoken to them, and ensured that there is a single person who is taking care of her through delivery and achieved a vaginal delivery also. But if we don't pay attention to that and don't understand that this could be the basis for which she is opting for a cesarean section, this issue will never get addressed. So these are areas that we need to address. And of course, postpartum problems are there. And these problems happen. Women come and tell us, I'm constantly awake. And it's easy to say, oh, yeah, babies will be awake at night. You have to learn to sleep in the daytime. But you can have to pause and ask, why are you awake? Why are you not able to sleep? Is there another caregiver? And then sometimes we get them to say, or they say, no, I don't trust anybody else to actually take care of this baby. Then if that line comes up, then that's a flag for attention. Or they think there's not enough milk. My mother or my mother-in-law or some aunt says that I'm not doing a good enough job. And this sense of, I'm not being a good mom is something that can add to the postpartum blues or depression that happens because of the hormonal changes. We've had situations where it's like a tug of war. The husband says, I want you to follow exactly what my mother thinks you should do. And then, but this woman, is much happier doing what she thinks she wants to do, or even if that is with the advice of the doctors or the lactation consultant or whoever has told her, in the context of the family, there is this additional pressure. So sometimes we as obstetricians end up having to call the couple together inside for what it is worth, the extended family, and tell them that these are the guidelines that we have given to them without bringing in the fact that the woman is feeling distressed. We have to communicate this as if it is advice that we are giving to the entire family. So the question is, as obstetricians, are we looking out for these women and for mental health issues? Now, we order a lot of screening tests. We screen routinely for diabetes by doing a fasting sugar or a GCT or whatever. And very valid, because, we are saying up to 20% of women can have gestational diabetes. We screen for preeclampsia, even though the prevalence is much lower, because it can result in mortality. We also screen for conditions like Down syndrome, where actually the prevalence is very, very low. Even if it is 1 in 600, we are screening, we're spending 15 to 20 minutes talking about it. But if you look at the prevalence of mental health disorders, irrespective of which part of the world you're looking at, you're constantly seeing this figure 10 to 15% antenatal, 15 to 20% postpartum. That means 1 out of 10 women at least are having some issues. But are we screening for this routinely, given its prevalence? And in majority of situations, the answer is no. And if we don't screen, we are definitely not going to pick up who is the person who needs help. So we need to know how to ask. And these are things that we have learned, and these are things that we are still incorporating into my own practice. And that is to ask, when we ask for past medical history, we never clearly ask the question, have you had anxiety, depression, or anything in the past? And it has to be, just as we ask, have you had diabetes? Have you had surgery? It's a question that we need to ask so that we are non-judgmental with the response. If there is a concern, then we ask more exploratory questions. How are you feeling? How has your mood been recently? How is your sleep? Are you coping well? Or do you think you need additional support? And if the answer to any of these questions becomes more, then either we could ourselves or we could refer after asking more direct questions and identify a referral pathway. There are red flag symptoms, and these are particularly true if you identify women who have had problems in the past, who have had issues of mental health in the past or had treatment in the past. And often this information is not volunteered. Increasingly, people are volunteering it readily, but sometimes there isn't, and you can actually have a very overprotective mother or a father who comes in, and those are flags for us to ask why is this situation happening, and then try and identify. So it's important for us to identify the need. The need is clearly there. And some of the things that we have incorporated is to have signages. So we have posters about mental well-being and pregnancy in our clinics that are there for people to see, offer privacy for a conversation. We have started incorporating some aspect of mental well-being into our pregnancy preparation classes. With the psychologist on our team, we actually offer sessions, group sessions on wellness, which is slowly picking up. And then those who actually have a need can directly fix an appointment, even if they don't tell us. So it's important to incorporate this personnel into our team. And I think therein is a challenge, because we need to capacity build and identify people who can get incorporated. But at least large obstetric practices should have somebody who is trained in this area and get incorporated into the team. I strongly feel that as obstetricians, we need to do a basic skill upgrade to do a good initial assessment, because by default, as obstetricians, gynecologists, we are, in the context of India, the GPs for our pregnant women. They do look to us as the primary caregiver, and there is a degree of trust which is built over a period of months, which is an advantage that no other medical professional tends to have across an access to women. And if we don't leverage that to help them in their mental health issues, I think we are doing them a big disservice. So, but we are not trained. Nothing in our curriculum trains us to identify or help women with, identify women who need additional assistance. And so that's an area where I'm very interested, and hopefully we will have some additional training going forward. And then have a clear referral pathway. Who is this person that you're going to send? And so that there isn't a loss between your sending them out to the clinic, they're then not able to get an appointment, they don't go to see somebody, or they see someone who's not speaking the same language as you. So those things also have to be incorporated. And last but not the least, because we are increasingly seeing more and more women who are already on medication for mental health problems, I think telling them you have to go off medication and then only come back to us is no longer valid. And we are not familiar with some of the more recently giving medications that are prescribed. So collaboration between the mental health expert and the obstetrician should ideally begin pre-pregnancy, so that we are also comfortable and we are able to take this woman through. And it's not important to tell them right at the start that you cannot breastfeed the baby, because you don't want that anxiety to start at 10 weeks or 8 weeks. If and when they can't feed, we'll deal with it closer to that time. But right now, there are other anxieties that she has, which we need to allay and take her through before the fact that feeding cannot happen. Because I'm saying this because I've had women who have come and said, no, is there no way I can feed my baby? Because that's important for them and we cannot discount it completely. So I think if we are able to keep an open approach, if we have an integrated care and we upskill ourselves so that we can listen to these women, we will do a much better job of giving them a holistic supportive care during their pregnancies.
Thank you, Dr. Ruma.
So I'll thank you and I'll
Yes.
stop. Yeah.
Your screen, yes. Thank you so much, Dr. Ruma, for setting the tone fantastically for the rest of this session. I think, you know, a lot of information that you just put out there was fairly shocking to at least me as a non-expert. And I don't think any of us outside of this field would have thought that this is the extent to which emotional health can affect both the birthing pre, post, and during. And to put this further into context, we have Dr. Ashlesha Bagadia, who is going to come in from the mental health angle, from the mental health perspective, and from the emotional perspective. I'm not going to say very much more. We'll just hand over to Dr. Ashlesha.
Thank you, Pavitra. Thank you, Dr. Uma, for that wonderful presentation. I think it is really heartening to see, you know, obstetricians and fellow colleagues also thinking about mental and emotional health. So I will just highlight some stories. And I know that I'm actually very excited to hear a personal story as well just after my talk of someone who has gone through mental health issues. So I'll start with the story of Seema, who came with her husband, and she'd been married for 5 years and trying to get pregnant. The setting at this time was also that, you know, they've been trying for a while, so there's a little bit of pressure. People are starting to talk about what's happening, why are you not getting pregnant? And at that time, when she starts seeing the IVF specialist, even just approaching the IVF specialist and the decision to go IVF also was quite hard. The specialist realized that you know, she's looking more worried than her usual patients, and she urged them to speak to a counselor. Although they were reluctant in the beginning, they actually started talking about their difficulties. They realized that, you know, the stress actually of trying to conceive had started to affect their relationship, and perhaps there had been difficulties that they hadn't talked about even before trying to conceive. Once they started becoming a little bit open and resolving this, her stress started coming down. And actually, she conceived naturally after that. While this may not be the case for everyone, what this highlights is that just being stressed, even before you start conceiving, just stress in the mother or even caused by the environment can affect the ability to conceive, can cause reproductive suppression and reduce fertility. And especially younger women who might have become, you know, who may not be in skilled positions, and also very, you know, working women who are in very high stress jobs. So it is really important to think about the impact of stress on your fertility, and if whether that can be addressed either through talking to the IVF specialist or the obstetrician or any other clinician that you're going to see to address this, but also think about talking about mental health. So I'll just talk about, you know, anxiety in pregnancy as well. Another person, Jasmine, who was a 25-year-old, hadn't expected to get pregnant and became pregnant unexpectedly. She had just started her first job and, you know, was actually looking forward to kind of settling into a work environment. And they were not financially very stable, but they were, you know, looking forward to maybe having a few years of working life. And suddenly she got pregnant. Although it was unplanned, everyone else around her was very excited. And she felt like she couldn't actually tell people how uncertain she was about this. And she couldn't talk about it because everyone was thinking, oh, this is great. You know, you should be happy. And she started getting worried. How is she going to manage? She's not prepared. What's going to happen to her job? Can she tell them whether, you know, that she's pregnant? What if she loses the job? How will that impact on the finances? And then she finally agreed to, you know, her doctor asked her to see a psychologist, and she wasn't sure. She said, no, I can't talk about these things. But for her, what really helped was her mother-in-law realized that she's actually very anxious. And her mother-in-law kind of sat her down and said, you know, told her own story of how she was pregnant very young. And at that time, no one was there to kind of suggest that this is probably not a right time for you, and how she had been very anxious and she didn't have any help. And the mother-in-law kind of encouraged her and said, you know, you are lucky that there are specialists now who can help you. Don't worry, I'll come with you if you're worried. And it really helped her to know that there were people around her who were encouraging her, and she was able to just talk to the psychologist, find out, how she can use some strategies to calm herself down so that she can start looking after herself, start looking after the baby, and how to look after herself better during pregnancy. So in this instant, what really helped was recognizing that it's okay to get anxious during pregnancy. You don't have to just be readily prepared and be happy about it as soon as you hear the news. And what also was helpful for her to know when she talked to the obstetrician, when her mother-in-law said how anxious she had been and she didn't know what to do, was to realize that if she stays anxious, she was avoiding talking to people. So people who are anxious might actually not access help when they need to. They may not even go to the obstetrician because they're worried that what if something comes up. They may not look after themselves. Her appetite had affected, and she was not eating properly. There's also risk of, this is too hard, I don't know who to talk to, no one else seems to understand because everyone else is happy. So a lot of these kind of things can have an impact on the mother, the anxiety itself. Being anxious can affect her ability to get help. Being anxious can affect her ability to manage the pregnancy well, but it can also have an impact on the growth of the baby. We have enough information now to suggest that if there is increased anxiety in pregnancy, then there is an impact on, the baby can get sensitized, baby's growth can get affected, and it can also affect, how the baby can be more sensitive after delivery. And the mother's chance of getting depressed or more anxious after delivery also goes up. So that was a story of someone who was very anxious and was fortunate to get help through her family members. Then I'll go into another story of Simran, who was actually very excited during her first pregnancy. She was looking forward to it. She had planned for it. She was eager to give it the best possible care. She didn't have any difficulty during pregnancy. She made sure she did everything right. She was doing yoga. She was spending time with her friends. She was also taking time for herself. She was sorting out her work, making sure she had the right amount of leave. And then the delivery also went okay. But after that, the baby had difficulty latching on, and breastfeeding became very stressful for her. The most difficult thing for her was to accept that, this is actually difficult, that the baby is struggling to latch on. Why is she not getting it right? And like Dr. Uma mentioned earlier, for her it became, does it mean I'm not a good mother if I'm not able to feed my child? Is something wrong with me? Everyone else is able to do this so well. Why am I not able to do this? And this kind of anxiety started making her to lose her confidence. And whenever she had to look after the baby, she would sort of, ask someone else to do it. She felt like if she can't even breastfeed, then she can't do anything. Her husband actually realized that she's seeking reassurance for small things, things that she could do properly before, like changing the diaper or, giving the baby a bath. But she constantly was seeking reassurance. She was asking people, just stay with me while I do this, or you do it, I can't do it, it's too much. And her sleep started getting affected. And she wasn't sleeping very well, so she wasn't able to, be alert and attentive during the day. So her husband took her to a lactation consultant who recognized that she was anxious and reassured her and said that while breastfeeding is very important, we will try our best to keep going, but it's not your fault that you're not able to breastfeed. So she was able to encourage her. She helped her to consult a mental health specialist, and together they were able to realize how to bring her anxiety down. And that doesn't mean that you have to stop breastfeeding, that you have to stop trying. But let's see how we can work together to balance the both. Sometimes someone else can take over. Maybe you can express milk and see if that works. So lots of different strategies were tried, but the main point was to reassure her. When her anxiety started coming down, she was able to feel confident even with the small things she was doing. And she was able to realize that there were times when she may not be able to do everything right. And there are others who can take over, there are others who can help, and that doesn't make her a bad mother. And together, the lactation consultant and the family were able to help her, and she was able to overcome this really stressful, anxious period. So the kind of symptoms we've talked about just now, highlighting what these mothers were exhibiting in terms of anxiety. There is a kind of a restlessness, not able to settle down. There's excessive worrying. Perhaps there's muscle tension. And especially for Simran, what would happen to her is the moment she starts thinking of feeding or the baby cries, she would start tensing up. She would think, oh my God, here we go again. I'm going to have to try this and I'm going to fail at it again. And that would make it harder to relax. That would make it harder for the baby to relax with her also. And it became like a vicious cycle. And anxiety can also present with just disturbed sleep. Sleep can be disturbed even when everything else is sorted. Now, of course, new mothers can find it difficult to sleep because they have so much going on. The baby can wake up anytime. But women with anxiety often say that, even when there's nothing to do, everything else is sorted, I just can't seem to switch off. I'm not able to calm down. And I don't know how to actually make myself go to sleep. I know I need to sleep now, but I'm not able to fall asleep. And so because of this, again, this adds to their ability to concentrate during the daytime. And they, especially for Simran, another thing, this obsessively, repeatedly having the same thought, I'm not a good mother, someone else can do a better job. And then they start avoiding. She was avoiding caring about the baby. She was saying, someone else do it. Maybe I'm not going to do a good enough job. So these symptoms can kind of manifest as anxiety, both in pregnancy and after delivery as well. And as I mentioned before, what can happen if this anxiety is not supported or looked after by the family members, by the mother herself, is that it can impact on the growth of the baby. For obstetricians who are also, looking at, okay, we have to make sure that the baby goes to full term. Sometimes anxiety itself can induce a preterm delivery. Babies can be more fussy, and there is a high risk of postnatal depression. And for all the the women that we talked about, they were able to recognize this, and with the support of the family members, they were able to ensure that these consequences could be avoided. So I'll go to the next person. And Salma had actually had a miscarriage in the past. Then she finally delivered, but the baby was born slightly prematurely and needed monitoring in the NICU. And for 4 weeks, their life was really, just going there, listening to doctor's advice, trying to figure out what to do next. Fortunately, there was no active medical intervention. The baby just needed monitoring to make sure that it can, function well outside of the hospital. But that itself was causing a lot of difficulties for Salma. Initially, she was fine. She was kind of caught up in this routine, following advice. They had to figure out how to express milk and feed the baby. So she was really busy. And then the baby started recovering, and doctors were happy with the progress, and they started talking about discharge. And there was a general shift in the mood. Everyone was saying, this is great, the baby's going to come home. But one of the NICU nurses noticed that Salma was not sharing this. She didn't look happy. She would spend the whole day with the baby. She would be there all day. She would do all the things mechanically, fill the form, sign something, express milk, feed the baby, hold the baby. But she looked listless and distracted. And she would also pass the baby to the husband. Not with the thing of, I can't do anything, but there was just no interest, or she wasn't able to be, sharing this happiness that everyone was feeling. And the nurse felt that maybe she's exhibiting signs of postnatal depression. She encouraged the husband to contact a mental health professional. Then, they were reluctant, but they recognized that Salma needed to actually feel better so that she can look after the baby well. So they saw a psychiatrist, and she started getting better. Baby was discharged. And the most important thing that the husband felt was that Salma was able to recognize and enjoy the early milestones, those precious moments that she might have missed out on if she had stayed depressed. So that she was able to do. And this is thanks to the nurse who picked up on it, because no one else realized, that perhaps she's not feeling all right. And often, just after delivery, there's so much going on. We may not be looking after ourselves. We may not, probably brush our hair properly. So there is kind of not that much of a focus on how the mother might be feeling or looking, and it might be accepted. Oh, she looks frazzled because, it's post-delivery. She has so much to do. Maybe she's busy. Maybe she didn't sleep very well. And it's missed that perhaps she's starting to develop symptoms of depression. And here it was really helpful that someone picked it up and was able to suggest that they get help. So what can happen in terms of the postnatal period? And after delivery, the first kind of few days up to first 2 weeks, is what it's very common. It's almost 75 to 80% of women will feel a general kind of feeling of feeling down, that blue feeling, which is called as baby blues. And this is so common that, because there's a whole crash in the hormonal system. There's a sudden change in their life. And there's a lot of readjusting to do in a very short span of time. But if it persists, and there is something called a psychosis, which is very, very rare, but it is also something that happens very quickly after delivery, where there is kind of a very lot of fear, paranoia, and maybe a little bit of loss of touch with reality. The most common thing that we see, apart from the baby blues. Now, baby blues, what happens is that there is a recovery. After first 2 weeks, they start settling into a rhythm and things start getting better. They start enjoying spending time with the baby. But if they don't, from around the 1 month or 6 week mark is when the postnatal depression actually develops. And this is really important to know, because what happens around this time also is that a mother, if you think about it, who has been in constant contact with the obstetrician for 9 months, has perhaps also just gone for a follow-up to the obstetrician, has contacted the pediatrician, has been seeing the pediatrician for baby care. After around 1 month, 6 weeks mark, the kind of care that the mother was getting it's not required, and she's not in contact with anyone who may be asking her how she's doing. So the obstetrician might have done a follow-up, and a lot of obstetricians actually now see the women a little bit later also, just to make sure that they're doing okay. Because around the 1.5, 2 month mark is when depression sets in. At that point, she's not in contact with any health services. And what can happen in postnatal depression is that there is a kind of a sadness, not feeling happy, not feeling, being able to join in the little small happiness of being around the baby. And that makes him start worrying that, okay, I should not be around the baby. The baby tends to cry more when I'm around. That what if I hurt the baby somehow without intending to? And there's difficulty in bonding with the baby. Now, all these thoughts are so unnatural that they start thinking, okay, this is something that I should not be feeling. And so something's wrong with me. I'm such a bad mother that I don't want to be with my baby. And the negative thoughts of guilt at having symptoms that they recognize as I should not be having. And then starting to think, wish she had never got pregnant. Thoughts of actually really feeling low and thinking maybe they shouldn't, even live anymore. This is something that they can't share. This is the biggest difficulty, is that not being able to share these thoughts with anyone, because they might think, okay, what is everyone going to think about me if I say that I wish I hadn't got pregnant? What can happen if mothers are facing postnatal depression, and if it is not picked up by their family members, is that they might have difficulty bonding with the baby. The baby, and as they grow up, might have forming difficulties in attachment in their other relationships. The baby finds it hard to regulate their emotions. And there may be long-term outcomes also, difficulties in the baby as it grows up. Of course, the mother also may have higher chances of problems in the next pregnancy. Now, if you think of Salma, the husband was able to get help. They were able to recognize. And the most important thing was that they were able to enjoy those early years with the baby and perhaps reduce the risk of a lot of difficulties that could have arisen in the future for them and for the child. Now, one of the things that I think we have to be really careful in thinking about this, and this is something that a lot of women have said, that the moment I start saying that be careful, if you're anxious, it'll affect the baby, then they start thinking, oh my God, I'm now causing distress to my baby. So you have to think of that it's not just the mother who's contributing to this. And there are so many causes that can lead to mental health difficulties. A lot of the biological things that we check for during pregnancy can also have an impact on mental health of the baby. So if the thyroid is not sufficient, if they have anemia, if they have vitamin deficiency, that can also contribute to anxiety and depression. And of course, diabetes that we talked about, Dr. Uma mentioned earlier. Now, there are a lot of external causes that we touched upon just through the cases. If there are relationship difficulties, if there is conflict, that can actually impact on the mental health of the mother. If there is not enough support, if they're feeling like, or if the reality is that they have to manage a lot of things on their own, that can actually contribute to their mental health. If there's any lifetime trauma, if there's financial stress, like we heard in the first, in the case of the woman who was worried that if she gets pregnant, the cause of the financial burden on the family. If there's stress from work, if there's stress from so many, like working alone, being a single mother. So there are so many of these things that can be causing and contributing to the mental health of the mother. And there are pregnancy related causes. If it's an unplanned pregnancy, unwanted pregnancy, gender of the baby, having multiple pregnancies, maybe with medical complications during pregnancy or during delivery, complications with breastfeeding, medical complications in the baby. So you see, there are so many things that can actually contribute to the mother developing mental health issues. So it's really important to not think that, something is wrong with her, that she is causing this, or she is somehow contributing to these problems. So as a kind of professional body, or even as family members, as a community, we have to realize, we have to try and see what we can do, and to think that this is the period, perinatal period is the time of highest contact with health services for a woman. For a generally healthy woman, she might never see doctors before or after. This is a time, is an opportune moment that we can make sure that she's both physically and mentally well, and to create an environment of reduced stigma. How can the parents, the mother-in-law, the father-in-law, how can the husband, everyone actually rally together to think that the mental health of the mother and of the family actually can help in reducing the distress for the baby. So whatever support is being offered, there's so many programs on nutrition, on lactation support, and lots of support around pregnancy and postpartum, to see how we can actually include emotional well-being in this as well. And Dr. Uma highlighted beautifully, how we can actually, professionals can ask about emotional health, to include these questions, to also remember that if during pregnancy and postpartum, you can have one contact with the woman that is confidential. This is something that a lot of women tell us, that, we don't know when to tell our healthcare providers, because we're never alone with them. So if you can spend a few minutes to be alone with them, just to ask them how are they doing emotionally, that can also be very helpful. Also, if you pick up risk factors, if you pick up that there's violence, or there's a previous pregnancy loss, if something you pick up that makes you feel like, okay, this is not, there's a chance that this can affect the emotional health of the mother, then don't ignore it. See what you can do. See if you can talk to the mother. See if you can talk to someone in the family whom she trusts, and get some help. And educating and encouraging family members is really important, and also looking at the impact. So if you talk about losses, sometimes fathers can get affected, the husband's baby affected. The stress of actually trying for pregnancy would have affected the husband as well. So including family members, checking for their mental health also is very important. Okay. I don't know what's happened. What can the mothers do? It's really important, of course, to be careful to look after yourself. Be wary of negative influences. One of the things that a lot of mothers tell me is that the moment they get pregnant, there are enough people to give me advice. Everyone has an opinion on what I should be doing next. So that is something that can be quite overwhelming. Of course, a lot of the advice is well-meaning, to think about what actually applies to you. What would you like to take on, and just ignore the advice that you're not interested in. And always try and be as open-minded as you can about options, because there is so much of decision making in a short span of time, so many options to choose from. If you're really fixed about something and it doesn't go your way, then that may be difficult. So be open-minded about options, and all the other things that your other professionals, healthcare professionals, might be telling you during pregnancy, to cultivate healthy habits like exercise, mindfulness, meditation, yoga. All that actually has a positive impact on your mental health as well. Most importantly, talk to someone. It's not necessary that you have to end up talking to a psychiatrist. In fact, if you just share it with your family doctor, with your, some doctor in the family that you trust, or your obstetrician, your midwife, nurse, someone that you feel you can confide in. It's really important that if you can talk to someone, that will really help you to share and to reduce your distress, and see what might be the best option to get help, if any help is required at all. And in the perinatal period, I'd like to leave you with this one message, that the small step can actually have a huge impact. So just small interventions by any healthcare professional that comes in contact with women during this period, small interventions by family members, small interventions by the women themselves, can actually have a huge impact. So I'll stop there. Thank you very much.
Thank you so much, Dr. Ashlesha. That was, really a very, very detailed idea of what, anyone in the healthcare system can look out for. And it was especially very informative for families who are expecting, and to just, I think the big problem is most of us don't know what to look out for. And if this information was out there a little more to say that the anxiety that you're feeling is could be something more, or could be dealt with by talking to someone, and just not brushed away, I think we'd all be doing so much better in this space. And our next guest will agree with that 100%. We have with us Ashika. We've heard from two experts, and Ashika is someone who is an expert in her own right because of the experience that she's had. And very admirably has been talking about it openly. And when we contacted her and asked her if she'd be willing to share her story, she was more than happy to. And one of the first things that she said is that this experience of having emotional and mental health issues during my second pregnancy actually made me come out better. And so we're really happy and really thankful to have Ashika with us. Ashika, I'm going to start by asking you to just give us a broad idea of what your experience was during your pregnancy, so that our audience understands firsthand what this looks like, what this feels like.
So I think can you all hear me? Am I clear now?
Yes, you are.
Okay, yeah. Great. So I think the first time I must have had postnatal depression after my first baby. Mm-hmm. And I think it probably went quite undiagnosed, because I went through the 2 weeks, the 2 months of super low, and then it went on for a while more, a lot more tears, a lot more emotional ups and downs. And then I think I just pulled it off and went on. I think the second time it really hit me was because when I was pregnant the second time with my baby, like 4 or 5 years later, I started having, it started with a certain amount of sadness, then it went into very severe depression. It went to, I think the point at which I realized I needed help was when I got suicidal thoughts, and it became I wasn't thinking about the 5-year-old I had or my parents. And I come from an extremely comfortable, stable, loving kind of a background. And there was nothing that was possibly actually wrong with my life at the point when this happened. There was nothing that triggered it. It was so completely overwhelming from a perspective of just, I guess, something that was chemically imbalanced inside my body, that I would sit up at night and think of different ways of which I could commit suicide. And there was a critical mind that was like, okay, these are the things to do. This is how to do it. This is where to do it. This is, the least painful, all of these crazy thoughts. And I'm a super positive person otherwise. So I think because I'm this extremely over-optimistic, positive person, I think people took it very seriously when they saw the change that was happening. Having said that, I think maybe it was the fact that I had, like Ashlesha said, very small changes or interventions can make huge impact, because the doctor I went to, my obstetrician, she picked up on it so quickly. The minute I said, I'm beginning to feel a bit like this, I don't even know what it was. And this is way before the suicidal thoughts even started. She said, look, why don't you meet a psychiatrist? I met a psychologist. I did a hell of a lot of talking, and I realized there were no emotional issues from my past. It had nothing, I was in an extremely happy place, but my mind had just, it was on loop of negativity, I was surrounded by love, happiness, we just moved into the home I'd been building for years. It was every, dream come true in a physical manifestation, but I had completely lost my sanity and my mind. And she moved me so quickly towards seeing a psychiatrist, and the psychiatrist picked up on it so incredibly efficiently and so compassionately, and actually pretty much didn't push me into medication, didn't push me to anything. I feel like the only reason I agreed to do this talk was because I feel like if these two parties work together, I can see the effect that it can have on patients. Today I'm back to 100 times stronger than I think I ever was because of the experience. But it was so traumatic that I feel like nobody I knew talked about it. Nobody I knew experienced it. I'm so close to my mom. She's a big healer, blah, blah, blah. But even she couldn't handle the idea of me getting onto medication. She wasn't so convinced that that was the right thing to do. You know, just meditate, be positive, do some yoga. I mean, this is stuff I do every day. But 2 days post the medication, I actually messaged the doctor and I said, is this placebo? Because it's impossible that I can be feeling better already. It's only 2 or 3 days of medication. And like, bam, I mean, I took it maybe 7 months at my 7-month pregnancy stage. And again, I was petrified. Everybody told me my kid would be affected by the medication, etc. I was on maybe the lowest Serta 25, I think the lowest dose. And in a week, I was so much better. I kept on doing it, I think, for maybe 6 months. Post baby, he advised I continue. And today I cannot tell you how much I'm 100 times better than I was even before I had the experience. So I feel like it can be a very empowering experience if you have the right support systems that kind of push you through it. So it's not even a bad thing to have. It's quite a blessing to have it, because you go much deeper into yourself and into your parenting and into every conscious decision you make. But I think the support system of doctors and psychiatrists and obstetricians is so critical, and of course family. So
I think everyone on this panel will agree that not everyone has quite the reaction to, receiving help that you did, but just to sort of, I know this was a while back, and but do you recall your first emotions when your obstetrician said that, perhaps you have mental health issues and you may want to see a psychiatrist? Was there any sense of, of hesitation, or, do you remember your emotions when you were first given this information?
To be honest, I think my first emotion was relief. I was like, I just needed to understand what was happening. I needed some kind of a diagnosis or something to understand that I wasn't just losing my mind. I had no idea what was happening. I was being difficult. I was cranky. I was difficult with everybody around me. The minute they said, I think you might be going through prenatal depression, it was relief. I cried out so many tears of like, oh, thank God somebody knows what I need, like at least you've identified what's wrong with me. Okay, now I know that there's a path out of it. You can tell me the path once I understand what I need, right? So I definitely think relief was the first one. Shame maybe, but I mean, it's far back enough for me to not be able to remember that the shame lasted. I don't think there was so much, but I'm sure there was some level of it. I know people told me, a lot of my aunts were like, oh, you don't need to talk about it so publicly. Why are you telling everybody? You can just go through it, but you don't have to make it such a public thing. And I was like, it's not my fault. I don't see, I mean, if I have blood pressure, you're not going to ask me to keep it a secret. Why the hell should I keep the fact that there's some mental, whatever, I don't know if it's instability or whatever it is, but some inconsistency that's making me uncomfortable. I think the fact that they made me look at it so much as blood pressure or a broken elbow or whatever it is, right? It's a condition, it needs help. Get the help, bam, you're back to normal or better. So to answer your question, relief was my big emotion, Pavitra.
Yeah. And that's something that we often hear even outside of the maternal mental health space. We know a lot of people who, when they receive a diagnosis, just are so glad that someone is telling them how to deal with this rather than but the stigma is real. And I'm glad that what you felt was relief and at the clarity that the diagnosis brought to you. But you also do talk about, you at the start of, while introducing yourself, you spoke about your support system and how you are surrounded by people who were incredibly supportive. Can you tell us a little bit about that and what kind of a role they played in your feeling and, your journey towards becoming better at fairly testing time like that?
Yes, I definitely think the support system was everything. Like I said, I'm normally so close to my mom, and she's so intuitive, and she's a healer, and she's one of these very, very exposed, mentally exposed kind of people, but she couldn't understand anything. Like, she was like, come on, let's pull together, let's pray, let's do yoga, let's meditate, you just need to do some gratitude journaling. And all of those things, I never felt more disconnected from her, because I was like, you're not listening, you're not accepting that this is what it is. I mean, it's one thing to pull someone out, but it's another to accept what they're going through and to stand by them while they go through a little bit of the valley before pulling them up to the top of the mountain immediately. And I feel like maybe that validation of this is real, this is what's happening to me. It's not my mind making up something, you know, it's not me looking for attention, because I don't need that kind of attention. I mean, this is the last kind of attention you want. I feel like that was a very stressful relationship, but of course she came out to be my, like, she and my husband were maybe my biggest supporters, and my mother-in-law as well. I think she also was able to come through a lot, because I think she has a sister. I think her sister went through something similar. Nobody knew about it. 25 years later, the family is split. She doesn't talk, the sister doesn't talk to anybody. When I was in it, I could almost sense that this is what she went through. Like, it was that easy for me to have lost all the relationships around me. I could say the most hurtful things. I felt so vulnerable and so easily offended over things that had nothing to do with, you know, personal things with me. I mean, I sent my father-in-law barrages of messages for everything that was wrong. But I think having such a supportive family that were able to accept and maybe just stomach it for a little while and then help me pull out, rather than just, I think the key is to also just acknowledge the person's position rather than only try and pull them out to a better place. I think maybe there was something valuable in that. But my support system was I mean, yeah, between psychiatrists who just came together like that, and literally like it was a net underneath me, and that lifted me up. So it was amazing.
Right. Ashika, if I may request you to turn your video off. I think we're having trouble with your connectivity, and so we can hear you better.
Sure.
And I'll just go on to my next question. And as you rightly said, the support system is so important. But I'm also wondering that that this is rather stressful for the support system as well as as a time. And do you, in retrospect, think that it would be great for the community to offer support to the family and the spouse at a time like this? So the extended community, do you feel like you wish they had more support while they were supporting you?
Certainly, I think my husband needed a hell of a lot of support, because he took the brunt of it, and like a real man would, I think he stood as stoically and solidly as he could, but like as soft and accessible as he could also for me. So I definitely think maybe having that support for him would have been great. Children are extraordinarily resilient creatures, and so they kind of just go with the flow and continue to give unconditional love even in the shittiest of times. So maybe they pull us through in magical ways. But I think the psychiatrist again was very good. And that too, it was a he, huh? So I started off the session and I'm thinking, how are you going to even understand what I'm going through? You are a man, you don't even understand these emotions. This is all related to hormones. But he was incredible. And he had Nikki and me for more sessions together, So I think it really helped my husband understand things that were harder for me to communicate to him. He understood how medically accepted it was, so it wasn't drama in my head. I think that was very, very valuable, is to do them together, as well as the option to obviously do it on your own, right? But I think when the way I could talk about my suicidal thoughts to the doctor is very different to the way you're able to tell your family members, right? Because you're aware of all those emotions. I'm aware of him thinking, how can you even think of suicide? You have a 5-year-old child, you have me, you have your, the rest of your family, how selfish. But when I talked about it to the doctor, and the way the doctor was able to understand it, I think allowed him to see it through different eyes. So I definitely think they do need a lot of support, but they need to be a part of that process a lot. And I think it's extremely important, because it's not her battle to fight on her own, right? Like it's in your interest to keep her happy and healthy. It's in the interest of your children.
Okay. We seem to have lost Ashika for a short bit over there, and perhaps we'll get her back a little bit later. But thank you so much. And I think we got a good idea of Ashika's story, in the way that she was able to join us. But truly admirable. And I think Ashika's story is one of those rare stories where the obstetrician was able to connect with the psychiatrist, and while working together, just as she said, that so much can take place, and that she was able to get past this very difficult time within 6 months, and like she said, she came out of it feeling better and being more courageous. I'll also take this opportunity to ask our audience to send us questions in the chat box on Facebook. Just type in your questions and we'll answer them towards the end of the session. We'll be moving on to a panel discussion shortly. You can also access our portal for any information that you want on maternal mental health. We are constantly pasting links in the chat box for you to access. If you have any specific queries, if you feel like you're not able to find any information, just please do ping us, and we will find the content piece for you. But in the meanwhile, at the moment, if you have any queries for our experts, we have obstetricians, we have psychiatrists, we have a lactation expert, and we also have Ashika, who has her own personal journey. So if you have any questions for any of the panelists, please feel free to ask us. We'll now move to the panel discussion, where we'll start looking at start asking questions based on the information that we gathered both from Dr. Uma's presentation and Dr. Ashlesha's presentation. If I may ask the panelists to turn on their videos. Okay. So first question, and I think to a great extent, both Dr. Ashlesha and Dr. Uma have identified it, how they see maternal mental health in their clinics. But if I may start with Dr. Prabha Chandra, who runs a perinatal psychiatry clinic at NIMHANS, and has been working in this area for decades now. Dr. Prabha, if you could tell us a little bit about how you see maternal mental health in your clinic. I understand that the cases that you see may come when the symptoms are rather severe. But what do you see? Can you give us a broad idea of your experience in this space?
Thanks, Pavitra, and what a wonderful morning this has been. I think, and thanks to Ashika for sharing her story. I think it's so important for us to hear the expert by experience, because they are the best experts, who can talk about this. So thanks for that. I think the kind of, so the perinatal clinic in NIMHANS has been running for nearly 10 years now. I think we see a range of women coming to us in a range of situations. So it's not so much only people who have very serious problems, but we get people, all the conditions that Ashlesha mentioned. So, we have situations where women have had perinatal grief, and that's a big issue, that they've had a past loss. It might have been due to an abortion, it might have been due to some other problem, and moms are really worried and scared and anxious about the current pregnancy. We have mothers who've had depression in the past and are petrified of having it again, and they come and ask us about whether they can conceive or not, and what are the precautions they need to take. We have women who have bipolar disorder, schizophrenia, other forms of OCD, and they again are worried because they know that taking medication is a bit of a challenge. At the same time, stopping medication may sometimes not be an option for many mothers. So, and then like Dr. Uma mentioned, a lot of obstetricians tend to feel that women should not be on medications while they're pregnant, and then women are getting these conflicting messages and they don't know what to do. So I think there's a range of conditions, and of course some of the more serious ones where we've got women with psychosis who need hospitalization, and we have a mother-baby inpatient unit where we admit mums and babies together. So I think it's a range, right from starting before they become pregnant, planning for pregnancy, till even a year after childbirth. So I think that's something that I want to emphasize, that very often we think the postpartum period is really just the 6 weeks, or the obstetric definition of postpartum. But actually, for mental health issues, we take the whole 1 year range And I think, like Ashlesha mentioned, it's very important that the mother's mental health be well for the child to develop appropriately in so many ways. In the cognition, in the emotional stage, social issues. So I think there's this whole range of conditions that we see in our perinatal clinic. So there's not just like one group of people.
Dr. Sonia, I think it'll be interesting to bring you in over here, and you of course see a very different demographic of women. And if you could tell us a little bit about what you see in your clinic to begin with, and then perhaps we can also look at whether the language around mental health or emotional health is different in from what you've heard from our other panelists so far.
If you see Chhattisgarh as a state, it has a very prominent tribal population. So you have a mixed group, you have an urban group, you have a rural group, and a semi-urban group. The most challenging situation is handling these rural patients who come with a very different language and a very different understanding of mental health. You see, they have lots of false beliefs about mental health. There are, beliefs about witchcraft, black magic. There are people who would think that these women who are behaving abnormally should be isolated in the village, and they are a risk to the rest of the village because they have some special powers. So that's a very unique, different situation. So when they are brought to the our hospital for a mental health checkup, we have a family which is not very supportive. They would rather go to a faith healer and get that feeling. They feel that those faith healers would be really healing to them. So convincing the family and the patient that this kind of behavior is actually a mental health issue, and that this is as biological illness like diabetes or hypertension, explaining that part sometimes gets challenging. So we try to explain them in a very different manner, that we use terms like chemical locha, or there's a disturbance of certain chemicals, so that they understand the medical aspect of it. The other very challenging aspect that when they come to us is, most of the women are not going to tell you I'm feeling depressed or low or and I'm not feeling okay. They don't come with the direct expression of feeling depressed. What the presentation would be something much more non-psychological. They would be presenting with more somatic symptoms. Like the family would be telling of late, she's been complaining a lot of headache, she's not been eating well, she's losing weight. And at times she's very withdrawn. So doctor, please, we don't understand why she's not talking to us. And she doesn't understand that she's depressed and that's why she's not talking. What she understands is that she's probably a victim of domestic violence, or, she has a husband or a family who is, stressing a lot that she should give birth to a male child. And a lot of interpersonal issues, in the rural belt, the women are quite overworked. They go to the village, they work for hours together. So even if they are pregnant, they don't get that much rest that they deserve. If they're tired, they're told by the mother-in-law. Even I have worked hard in the fields, it's no big deal. And if you're beaten up by your husband, it's again not a big deal. Even I was beaten up. And this state has a lot of substance abuse, like men abusing alcohol is a very, very common, both rural, urban. So when they're drunk, many of the times they are beating her up because she's not fulfilling their sexual desire. So, and this is such a personal issue which she cannot tell her mother-in-law or complain to anybody else, even the Anganwadi worker or the Mitanan who happens to visit her sometimes. She can't disclose these issues. So, she's just internalizing it, and she would turn up in our clinic in a format like she's, just fainting and falling off. And then you are wondering, is she an epileptic first? Usko mirgi to nahi ho gaya, and then the whole family would be telling us, please investigate her, isko jhatke aa rahe hain. And many a times it's not epilepsy, it's, it's a lot of psychological distress being expressed in her need for help is being expressed more in a physical format, because I think somewhere our Asian population especially feels that physical problems would be understood by doctors much better. But she is very fearful to disclose any mental health issue because for another angle that she might get stigmatized, she might be isolated, and she might even end up getting a divorce. It's so high there, okay, ye pagal hai, ye shadi ke laik nahi hai, and she might give birth to again a mentally ill child. She cannot be a good mother. So, we rather not have this child from a lady who's mentally ill, and that's very distressing. So, to handle the family and educate them is quite a challenge. And of course, to give her the privacy and the confidentiality to elicit these issues from her, the kind of social issues that she has of, probably like I mentioned about domestic violence or sexual abuse, or, she being not being treated properly, this lack of that support system that she deserves, the emotional support that she deserves from the mother-in-law or the husband, when that's lacking, you see these patients being manifested in quite a different manner, rather than just saying I'm feeling sad, low, or I'm suicidal. They may not come out with these kind of symptoms at all. Mm-hmm. So this is, I thought, a different, so you need to understand their psychological awareness. So you need to, establish a rapport and connect. And then this first step of making her feel cared for, as a therapist, I feel that initial 1 hour with her, in which we can give her confidentiality, give her a space to connect with us alone. I think that's so crucial in establishing what kind of a problem she's having, and then doing the management plan. And the other thing that there is a lot of myth about medication during pregnancy in this population. They would be coming like saying, Angrezi dawa se to nuksan ho jayega bachche ko, band kar do. Stop all these medications. And mostly our GPs or who are the rural practitioners, they are also having that knowledge that the focus should be on the baby. The medication, if ever she's going to be given, it will harm the baby. So the first step, even if she has had a past history and she has been treated, say, by us, first she would not disclose it to her in-laws that she has received treatment because of the stigma. And the second issue would be what loss can happen to, what harm can happen to the baby with the medications. So, many a times they make a very abrupt decision to stop the medications. So they would just say, if you can talk her out of it, I'm happy. But as clinicians, we know that nearly 10 to 15% of them suffer from very significant anxiety and depression. It's not mild, which can just respond to a talk therapy or counseling. She would require medication to avoid the risks which Ashlesha pointed out. So to convince them that medication is helpful, so the risk-benefit ratio, to explain to them in a language which they understand, is again a very crucial aspect of our strategy to establish treatments.
Thank you so much, Dr. Sonia. And I think that brings me to, one of the most important parts of this discussion is to look at the social angle of emotional health of mothers. And I think I'd like to open this question out to the whole panel, and perhaps we'll start with Dr. Roma and then go to Dr. Prabha and Dr. Ashlesha. But to sort of recognize that a large part of this is often not medical. And so as a practitioner or as the family and support system of a woman, what do we really look out for in terms of saying that these are the social issues that surround a woman? And I know that you have touched on it, but just to say that here's what I wish, the 5 things that I wish people knew, and here's what we can look out for in terms of social issues that kind of nudge us towards having worsened emotional health.
I think the first thing is for us to be aware that women come from different situations. As Dr. Sonia said, I mean, even within an urban context, there are women who come from families where they have no choice, they have no decision-making power. And sometimes, as people who have always had that privilege, it actually takes us time to understand that this woman has never had that ability. So I think the first thing is for us to be aware of the fact that women can come from different circumstances. And secondly, to always have that, the context of the family is very strong. A lot of decision making is never the woman or the couple. There is always a larger family angle to it. And therefore, it's not very uncommon to have 4 or 5 people come into the first antenatal consultation. It's not happening now because of the current time, but in general, it's not uncommon to have 3 or 4 people walk in. And Sometimes so it's, I think, a little bit of a knack that you learn with time as to who is this control, or who has the control, or who is this person that you need to actually take on board so that this woman can be given the best possible care that she needs. Now that's, I don't think there are any rules about this, but it is something that we need to be aware of. And having a conversation with the woman on her own over a period of time, sometimes they are happier to tell you, which is the way to address it. And not to minimize the stress that she's feeling, because it may not be a big deal. It may be, you may yourself think that that's not such a big stress factor. We have worked when we are pregnant. Why are you making a big deal of it? But I think if they are vocalizing it, then we have to give it its due. That is the other point that I'd like to emphasize. And then see how best we can support and help.
Dr. Prabha, and after that, perhaps we can also hear from Dr. Shaibya as well.
So I think that, it's very important for us to recognize that each woman's experience is very unique. And though we have all the research which tells us that, these are the risk factors, every woman brings to this pregnancy a whole life history of hers. So I think it's very important for us to recognize that unique vulnerabilities exist in different women. So in terms of social factors, there are women who've had a very difficult childhoods. There might have been sexual abuse, there might have been physical abuse, they might have struggled with body image concerns, they might have had substance use. So there's a range of things that they bring into that pregnancy. So I think it's very important for us as practitioners to not look at pregnancy as an isolated event in this woman's life. That there is a whole range of things that she's already experienced. And in case she has an unwanted pregnancy, a majority of pregnancies in India, and I think even across the world, are actually unplanned, but sometimes they are unwanted. And I think unwanted pregnancies are a big stress. So that's something that we need to be very aware of. So what's the kind of life this woman has led in the past? What are the kind of vulnerabilities she has? And then subsequently looking at, was this a desired pregnancy or not? Sometimes it was not a desired pregnancy, but over time the woman kind of overcomes it and starts accepting it. So I think that's important. We also don't seem to pay enough attention to what are called life events in the year prior to pregnancy. So when a woman comes to an obstetrician, in the past year, she might have had losses. She might have lost a job. She might have had a bereavement. Somebody close in her family might have died. There might have been a financial issue. There may be dowry issues going on. So I think recognizing that, again, life events have a major role to play, and just checking whether, how life has been in the last year for this woman kind of highlights the problems that may have come up. And the third thing, I think a very, very important thing is the kind of support she has, which has been highlighted by everybody. But let's say a woman has got married and she's moved from her maternal house to a completely different city. All she has is a husband, whom she does not know really very well. And here she becomes pregnant within the first 6 months of her marriage. I think just the feeling of isolation, not knowing people. Sometimes we get women who come from the north to Bangalore, who don't know the language, local language, have not been able to really mix with people in their apartment, tending to feel extremely isolated, and then they find themselves pregnant, and there's no option of going back to the maternal house. So I think these are the kind of situations, in addition to, of course, the more extreme ones like partner violence. But what studies have actually shown that those women who had trauma in the past are really more vulnerable, both to problems in pregnancy and in the postpartum. And I think these are some of those women whom we really need to flag and try and understand them better. And they will very often present with the kind of situations that have been described, with a lot of anxiety, with concerns. And in the postpartum period, and I think I'd like to come to that a little later, maybe in our discussion if we have time, is that very often mental health problems present as a mother-infant bonding disorder. So women may be brought to us or come on their own saying, I don't feel a thing for my baby. I'm not able to bond with this child. And sometimes it's like, I was able to bond with my previous child, but with this child, I'm not getting the affection. And the family members will say that, you have to push her to feed. She doesn't see, and the father will say, I have to look after the baby at night. She doesn't seem to care. And when we look behind it, there are probably other psychological issues. So I think these are some of the things that, we need to be really aware of in terms of what you said about the social risks which are there.
Dr. Shaibya, if you could come in on this and tell us a little bit about what you see in your clinic. I understand that that you see a lot of your patients for the longest period of time, starting from from the time that they're pregnant all the way to when they're feeding. So you must see social issues play out in front of you for a fairly long period of time.
Yes, I do actually. And I think when we talk about emotional or mental issues, the need to build rapport, because it's not possible sometimes in the first time itself for a person to be open about it. And I feel it's very important to understand the person who's sitting in front of me. So as you know, the previous speakers have pretty much covered everything. And what I would like to say is, like, I like to know how their childhood was. Where did they grow up? Where did they study? Were they bullied in school? And that's where what Prabha had mentioned, the body image issues. The things like, was this a marriage that they wanted? Were they ready for marriage itself? And then we know that 38% of migration of women occurs with marriage across India. That means a woman is in a different place right now from where she grew up because of marriage. The changes in her job, she has to change her job. She worries whether she will lose financial independence. These are all things which are very, very important. I have now started asking, whether they had problems which seemed like depression during school and college days. Because I do feel that our education system in our class 9, 10, 11, 12 really triggers issues in young women, which affect them, which may continue later on also. And a lot of them do say, yes, I didn't give an exam, or I missed exams, or I withdrew from friends and things, which gives you an indication something may be happening. So that importance of understanding their previous issues. Of course, unwanted pregnancy, and 90% of Indian pregnancies are accidental. People become pregnant more easily than they would buy a scooter or a car or a flat. The amount of thinking and, financial discussions and discussions between all the people involved for buying a house or buying a car or a scooter is much more than in a pregnancy. And I'm horrified because you're talking of a life, and, you have to take care of the child for life. The third thing I often ask is there a senior woman, experienced woman to help give confidence to the girl? Now, sometimes some of the women have lost a mother, but sometimes I have seen a wonderful grandmother who has been like, the mother, it has been in the place of the mother, and she really takes care beautifully. But if there are issues between the girl and her mother, and here I often ask about the number of siblings a woman has, all girl children, sometimes 3 girls and then the 4th boy. This girl is the 3rd girl. And she really sometimes feels not just unwanted, but she has been neglected by the parents. So the gender issues of this woman herself while growing up is going to impact, because sometimes they say things like, I want a boy child because I don't want any girl to go through what I have, things like that. So these are concerns. The other thing is the spousal support. And here sometimes when the young couple comes, sometimes they've been going through fertility treatment. So the husband has been there pretty much. And after the initial congratulations, when the pregnancy test comes positive, he vanishes. He doesn't come for any of the checkups. And I have noticed when I speak to husbands, and the wives are sometimes a little irritated, what happens after pregnancy is the woman wants the man to sit by her, come back in the evening, talk to her, spend a little time. And what happens to a man when he becomes pregnant is that he suddenly says, oh my God, I have a child coming up, I have to pay school fees, college fees. And he suddenly starts spending double time at work. out of genuine care for the fact that his wife is pregnant. But what the wife feels is he's never home. He's on calls. He's taking up extra work. He's traveling more. Doesn't he care for me? Because for a woman, it's about having a baby with this man. And for the man, it becomes about fatherhood. I need to be responsible as a father, not realizing that he's giving up on emotional issues.
Right.
So sometimes I just discuss that with the couple for them to understand that these are things they may be going through.
That's really quite fantastic, and I can't imagine what it is like to sit in your clinic and have a long chat with you, Dr. Shaibya. In fact, I know from several friends in Bangalore who've told us that your consultation timings are around an hour per patient, which is an indication of the length to which you try to understand your patients and the people who come to you. We'll come back to that as you know. We'll come back to the process that I understand we have a lot of obstetricians who are listening into this conversation. Perhaps look at what kind of questions obstetricians or general physicians should look at asking their patients. But I'd like to bring in Dr. Ashlesha to talk about the social issues. I know you covered a lot of it in your presentation, but if there's anything that you'd like to add to this.
No, yeah, thank you for that. And it was really nice to hear Dr. Saldanha as well, because, it's for us, it's very heartening to see that Dr. Uma, Dr. Saldanha spend a lot of time with their women, trying to understand them. I think that is the most important thing. So one of the things I'd like to add here is that, again, touching on what Dr. Sonia was mentioning earlier, that we might see women coming from all different walks of life, and they might make choices that we may not agree with. And that is another thing, their family members may make choices. Often, one of the difficulties that we're all facing is that decision-making is not necessarily the mother's alone. She's kind of coerced into it. She doesn't know whether she wants to get pregnant. Someone else wants a male child. Someone else wants, so there are so many reasons that they become pregnant. Sometimes they don't even, they're not preparing for it. And often, you have to be very careful that we're not sort of imposing our ideas, that she should be getting this autonomy of making all the decisions by herself. How can the family not help her? So I think what Dr. Uma mentioned was really good, to think that when you see a person, it's important to think what's going on in this family, to not get too caught up in thinking that, okay, I'm going to empower her and make sure she makes all the decisions, because she may not be able to carry it forward. You have to, make sure that the family members are part of that as well. There must be someone else who will be able to help her in carrying this forward. She may not want to take all the decisions. So whatever our ideas are as professionals, healthcare professionals, or even people who want to help, we have to be careful that we're not judgmental about the women in front of us, that they may have a different way of approaching. As long as we are able to recognize that we have to give them all possible options to reduce their distress, whatever way in which they can. So socially, I think it's really important that different people may have different ideas, different plans, ways of bringing up their children. Whatever their choices are is valid in the women and in the family members as well. Another thing that we're also noticing, which maybe I don't know if it's a social as much as possibly social, is that women don't often deliver where they might they might be getting antenatal care. And so I think there's a lot of movement. They deliver, they go off to their mother's house perhaps, and there is a break in care. They don't follow up with all the excellent advice that might have been given earlier. And so that, I think, is like a logistical difficulty, which also happens, more common, I suppose, in India, because they go away to a different town. And so how do we ensure that there is enough communication between different health professionals who might be, especially women, let's say they're on medication or having some kind of mental health input, and then they go away into another city, and, they have to continue care there. So I think it's just making sure that there is engagement between all the different healthcare professionals would be quite useful in tackling these kind of situations.
Thank you, Dr. Ashlesha. That sort of brings me, Pat, into my next question, which is on the importance of different healthcare professionals, understanding that they play a key role in identification and escalation where there is a need, or even sometimes in just helping mothers and their families, cope with this situation better. And I'd like to go back to Dr. Saldanha for this. And, because you have a process for yourself, and you build a great rapport with with the women who come into your clinic, and sometimes with the families as well. But if you were to talk to, other healthcare workers and say that, here are the things that you could possibly ask, or here are the questions that have given me very, very insightful answers, what would they be? Or if we flip that around and said, I wish patients would come and be prepared with these kind of answers, sometimes to say that, here's what I'd like to share with you. So I think we'd like to, work with both of these audiences, both the healthcare workers from, the range of interactions, and perhaps even women and spouses who come into your clinic.
So as Dr. Prabha had mentioned, this child, is this pregnancy wanted? Was the first thing. Was it planned? Has it come too early? Or has it been something which has waited a long time, so a lot of anxiety has built up? Certain things like age, so many women come to me at 30, 32, 34 telling me, I'm very old. And I'm like, no, you're not. And this concept that at 36, 38, suddenly something happens to your systems because of which, something's going to happen to your baby. And I keep explaining to them that in the West, it's not like that. It is your fitness which is important, not the age in carrying the baby and going through. I don't think it's necessary to really frighten women about diabetes and high blood pressure and things like that when they come in, just because they happen to be 34, 35 and this is their first pregnancy. I think we can watch out for them, do the tests, tell them what are the issues, but not scare them. And I think that is very important, giving them confidence. And I often ask women, and I would like health workers to ask women, what are the things you worry about? And as someone had mentioned, they have a friend who's told them a terrifying story of labor. They have a friend who's lost a baby. They may have people who have had problems, who've had a child who has some special needs. So all these things are worries. Another thing is, I often ask them, do you get nightmares? And when they ask, then they look at me blankly. I say, pregnancy, especially the first one, is such an unknown thing. And like for our exams, when we went for our exams, it was very unknown. We would often have nightmares about going to the wrong center, going for the wrong exam, studying for geography when it's history, things like that. The same way your pregnancy is an unknown to you. So you'll often think of it. And I then ask them, what is the biggest unknown in our lives? And then either the husband or wife or mother will say, dying. And I said, yes. And therefore, very often, you may have dreams about dying, about the baby dying. And when I say it, I see this look on this woman's face saying, yes, I do. I have night dreams that I've died, and then, people are running around. And I said, that is just that your subconscious is saying something to you about a worry, and it doesn't mean you're going to die. And so spaces like that, so health workers can ask things like this. I don't know why sometimes death or anxieties are things we feel scared to talk about. After delivery, I have often spoken to women saying when they've come in their second month, do you sometimes feel like leaving the baby and just running away? And they go, yes. I said, do you want to give the baby away to someone saying, I've done my job, I've had the baby, keep the baby, I'm out of here? And they go, yes. And the feeling that is natural, that having a baby is a 24/7 job, which is terrifying. You have this little life in your hands and you think, if I don't do my job properly, something will happen to my baby. Is very scary. And so being able to bring that out for women and then talking to them, because they feel like at home, don't talk about these things. It's not good to talk about negative things. So I also, when I discuss these, like the husband and whoever the senior women in the house, caregivers coming in some families, especially now during Corona, a lot of couples have not been able to go back to their parents' home. Neither have elders been able to come here as was planned. So they're very alone. And they are facing, so a lot of times you have to be loco parentis and trying to explain to them simple issues which they need to look at and worry about, and what should I go to a hospital for, what are the things I should look at, which an elder mother or someone would have been able to help with them. So these are things I would like health workers to really say, what are you worried about?
Thank you, Dr. Saldanha. And Dr. Uma, would you like to come in on that question as well? You did mention that you have a list of questions that you have for couples who come in.
Yeah. So I think, asking a question that clearly that is unambiguous in the way we ask, is something troubling you? Is there something that you would like to discuss with us? Is one aspect, as Dr. Saldanha mentioned. The other is if they ask a question, and that's something that I wanted to mention in the context of the social issue. If they raise a question, sometimes we need to pause and ask ourselves, why is that question being asked? So the common question will be, can I travel? Is it safe to travel? And you would normally say, yeah, of course it's safe to travel, and leave it like that. But if the question comes more than once, then you're asking, can you tell me why, why are you asking the question? Is it important? Where are you planning to go? And then it will come out that actually I am in my husband's place. My parents' hometown is, a 2-day journey, and they feel I shouldn't travel, or I may miss an important scan if I don't go now. And then we have all these contexts of 3rd month you can't go, 8th month you can't travel. So, sometimes when they ask you, which month am I on? Then sometimes we end up saying, the calendar month and the way we calculate weeks are slightly different. So actually you're not in the 8th month now. I mean, so when it's a question of trying to understand what is the anxiety behind the question, and then try and address that as well. So I think asking, and I think clearly asking, is there support? And are there any issues between, if you feel that there is a problem, then asking, is there any issue? Would it help for me to talk to your husband? Would it help for me to talk to your mother-in-law? This is something that I do ask. And sometimes it is, would it be helpful for us to talk to your parents also? Because it's not as if everyone, as was mentioned earlier, has a, hunky-dory relationship with their parents. So, and if we realize there is the problem, then that's going to possibly affect their own parenting and the way they bond as well. So I think these are some of the questions that that we are now increasingly incorporating into our conversations, and just lay it out there, put it out there that we do have a psychologist as a part of our team, and you can approach them if you feel that at any point. It's common to go through stress in pregnancy, and if at any point you feel the need to talk to somebody in a little bit more detail, you could. If you have the luxury of having a psychologist as part of the team, I think it's useful to do that. Women in general are happier if you just say psychologist, because they are still a little anxious about what it will mean if they go to a psychiatrist, and they automatically think they're going to get medications. So that is another area that we need to negotiate.
Thank you, Dr. Mora. Absolutely, and I think even when we were discussing, the questions for this panel and the topic for this summit, I think both all 3 psychiatrists who are on board very clearly said, you're going to scare people away by using the word psychiatrist, so we may want to talk about emotional issues, which is possibly true, and hopefully that will change soon in the near future. We'll start to take a few questions before we come back into the discussion. We have a question from Deepa Santosh, who talks about birth trauma and says that it's a huge cause for mental health issues postpartum and possibly for the next pregnancy. I'd like to bring in Dr. Sonia to give us her views on this, and also what do we look out for? How does birth trauma affect the mental health of women?
Yes, sir. Birth, especially, example, she had an episiotomy which was very painful, or she was not attended well by the health workers who were there, the midwives, during the delivery, or in fact even the gynecologist was very anxious or rude to her, and didn't understand the pain and trauma that she went through. So there are lots of women who find that an extremely stressful experience, and that stress is so much that it leads to kind of a post-traumatic stress symptoms. She keeps on recalling that past pain, and that anxiety is so significant that it disturbs her sleep, her appetite, and she's restless, and she wants to avoid a second pregnancy. If she had, say, a difficult labor, she would rather say, I want a cesarean next time. Maybe I don't want to go through these labor pains because I didn't have a very, respectful delivery. So I think this is one thing where the obstetricians and their team has to be very careful. You know, ensuring the dignity of a lady during delivery is so important. Like in the West, you know, you're allowed the husband to be with her and in the room, and you know, she's provided a much better ambience, in fact. But in our setups, she hardly has privacy, even her during her labor. She has another 6 ladies in the government setup delivering at the same time, and she's being screamed upon when the labor pains are not progressing, or she's experiencing pain, and everybody is trying to do a PV on her. And you know, suppose they're going again for a forceps delivery, and then untrained people are attending onto her. It's very, very traumatic. So that could prevent her, you know, from going in for a second delivery. These issues have to be addressed, and she needs to be counseled and reassured. And you know, her feelings have to be acknowledged that yes, we can understand what you've gone through. You didn't deserve this. This was a mistake on the part of the treating team. And once she's listened to, and she's reassured, you know, that she would be getting a better place and a better reassurance, she comes out of it. So this has to be addressed. But if it's not addressed, she would just avoid a pregnancy. She would say, I don't want a second child because it has been so traumatic. So one has to address this issue. And many a times you require a good therapist to get her out of those post-traumatic symptoms. You know, if they keep on relapsing and she keeps on thinking and she has bouts of recalling that event, then you know, in some vulnerable patients, we even, not just therapy, we also add certain medications to calm her down if it has reached to that extent.
Dr. Prabha, if you could, you know, I think we've had this, there was a discussion, I think, during the Masi conference about how birth trauma affects how a mother can care for her baby. Could you give us a little bit about, tell us a little bit about that, the effect of trauma on the mental health and of not just the mother, but her ability to bond with her baby thereon?
Yeah, I think, you know, like I briefly mentioned in the past, and it's been sort of talked about by many people, multiple traumas, particularly sexual trauma, has a great impact. And we now discuss something called transgenerational transmission of trauma. That is, if a grandmother has had trauma, you know, the grandmother transmits the effect of that trauma on the mother, and the mother then transmits that effect of the trauma on her baby. And so trauma is so important in terms of the kind of changes it makes to not just a person's mind, but to also what we call the DNA. There's something called epigenetic changes which happen, which kind of go transgenerationally. And that is why I think protecting people from trauma women from trauma is very important. Women who are traumatized tend to have anxiety, and they can find it very hard to bond with their baby. It could work both ways. Sometimes they're exceedingly cautious. So we've had a mother who would not let the baby out of sight, would not give the baby to anybody because she's so worried that something will happen to the baby or somebody will do something to the baby because she's had such a bad childhood experience. So there's overprotection, or some mothers are just, it's so overwhelming to look after the baby that, like Shaibya mentioned, let somebody else look after this baby. And I think there are now several interventions which are being developed, which are what are called dyadic interventions, that we work both with the mother and the infant together to allow the mother to learn how to understand the baby's needs, to increase her sensitivity, to make her reflect on what is the baby trying to tell you right now, you know, and what are you feeling, and maybe even acknowledging the anxiety that she goes through. And I think like what Sonia mentioned and the question that was asked about obstetric trauma, we find that moms who've gone through previous trauma and have had obstetric trauma, you know, when we think of obstetric trauma, we only think of the big things sometimes about episiotomy being done or, you know, it being a difficult delivery, but sometimes just having a PV being done without her consent, clothes being taken off without her consent, without telling her what we are really doing. Sometimes small things like that can actually be extremely traumatic for women who've gone through past trauma. So I think you know, dealing with some of those things are important. And it really, we find that perinatal mental health actually has a new name now, and it's called mother-infant psychiatry or mother-infant mental health, because it has a large impact on that dyadic relationship. And some of the things that we do are, in addition to working with the mother separately, we also use videos as a method of giving feedback to the mom. So we ask the mom to play with the baby as she would, take a 10-minute video and actually show her the video and say, okay, what do you think is happening here? What is the baby trying to tell you? Why did you look so anxious at this point? What made you so happy at this point? You're doing a great job here. How could you make this better? So I think just doing all of that is very important. So I want to tell people out there who are listening to us that there are many interventions that have been developed for these conditions, which are not only medication, but a lot of therapy. There are a lot of therapists available in the city, at least in Bangalore and other parts of the country. And we are hopefully going to bring out a list and a directory of mums, of practitioners, both obstetricians and psychiatrists and psychologists who work with perinatal mental health. So people who need help should actually access help. And I think that's what I would like to end with.
Thank you so much, Dr. Prabha. We'll definitely be looking out for that resource, and we'll be listing it on White Swan Foundation for sure. But going on to another question that we have from, to do with the current situation, there are a few questions that are coming up with reference to COVID-19. Sangeeta Jain asks, that the risk of perinatal psychiatric incidences are increasing during a time like this, especially when it comes to women with diagnoses like obsessive compulsive disorder. You came out with an advisory for pregnancies during a time like this, and that's also available on our portal. But if you could talk about the what happens at a time like this, what happens when you don't have access to your psychiatrist, or you discover that a pandemic like this is making you more anxious than you were.
Yeah, I think we've sort of been seeing a surge of increase in calls by pregnant women, and this must be true for all the obstetricians as well as the mental health professionals on the panel, that there's been an increase in anxiety and related questions. So I just have a woman right now with me who I'm caring for, who basically feels that she's got the infection and she's going to pass the infection to her baby. And that's because the family she lives in is not very hygienic. So she can't go to her mom's place. She's with her in-laws, and she feels they are not being careful enough. They're not sanitizing enough. They're not, careful enough about hygiene. And so there's constant worry about, will I get the infection? Will I give the baby the infection? And this is in the postpartum period. In the pregnancy, mothers are asking us about, should they go for a scan or not? If you go to a hospital, will you catch the infection? And I'm sure the obstetricians in the panel will answer a little bit about that. The third thing, I think a lot of women are not able to go through the rituals that they are used to. And this is a huge thing for some women and huge thing for some families, where they all get together and have that 7th month or 8th month ritual, or once the baby is born, have a ritual. So I've been trying to tell women to do things which are still celebrating the whole pregnancy, but maybe without the kind of ritual which normally happens. So I think there are these multiple challenges for different reasons, and sometimes they all come together. A lot of it is related also to the use of sanitizers, excess use of sanitizers. Is that going to cause a problem to the baby? So mothers who already are anxious, who have some sort of obsessive compulsive kind of traits, are actually reacting much more.
I'd like to go to Dr. Shaibya with the same question, and also add another question from Mahesh Natarajan, who asks, there are a lot of unplanned pregnancies during a time like this, during the lockdown, and people are struggling. Some want to terminate their pregnancies. Some are worrying about the future of the baby, and there's guilt and anxiety and a whole number of emotions that are coming into a situation like this. So if you could take both of these questions, both to do with existing psychiatric issues and also new anxieties, and what if you haven't planned a pregnancy at a time like this?
So I think about 2 weeks ago, there was a WHO letter which came out that there will be 72 million pregnancies in this COVID time, which probably would have been terminated, which would not have continued. But because of lack of access to contraception or early intervention in terms of MTPs, they have not been able to, and these pregnancies will continue. And you can imagine the strain on a family to manage a baby they were not planning to have, and definitely the mental health issues for the mother. So I think this has been a big issue, and somewhere world over, we're not going to get into this over here, but I think the way the medical management of COVID and of particularly of women, we do know that women and children are the ones who are going to suffer the most whenever there are any disasters, and we would consider this a health disaster. So very much so that I think a lot of my friends or gynecologists have been speaking about the fact unplanned pregnancies, especially in young women who are unmarried, a lot of pregnancies happening, having to take medicines in an unsafe manner because they're not able to access doctors, they're not able to access the proper medication, and this is a huge health issue which is completely hidden because these are girls who are not even talking about it. So unmarried pregnancies, plus of course pregnancies in marriage not wanted, and we will not see the fallout till many months later.
Right, right, absolutely. And at a time like this, what are the options? And I think I'd like to throw it out at the panel. It is a difficult time, and the access to care is limited. What can families look out for, or partners do at a time like this in terms of emotional support, if there is, if they are going through a pregnancy? Is there an option if termination is the choice?
Yes, of course, there is termination is always a choice. I mean, I would always say that the one thing I would wish for every baby is to be wanted, because that's something that you carry for life. So if a woman is not wanting a pregnancy and she's got pregnant by mistake because of lack of contraception, definitely she should be able to get termination done. And it is possible to go to hospitals. There are some hospitals in every place which are non-COVID, where they can go and access health and care. And it is not dangerous to go to hospitals unless you're going to a specific COVID hospital. It is absolutely fine to go to a hospital. Call them earlier. There are all hospitals have a system by which they allow only one attender in. They check the temperatures. They ensure that minimal chance of COVID positive patients coming in. So there are certain protocols hospitals are handling, which tries to ensure that the patient is, and you sanitize when you go to the hospital. You do your checkup. When you go home, immediately get into a bath, take off your clothes, put in the wash, and then you're pretty safe. And you wear your masks all the time, hand washing all the time. And your risk is no much more than if you went to buy vegetables. I think it's pretty much the same if you're going to a hospital which is not a COVID center.
Right.
So please definitely access health. Please take your checkups. Don't delay your ultrasounds and things like that. You may not go more frequently. You may reduce it. Certain problems you can talk to your doctor on the phone and they can get it answered. But definitely the regular checkups should be followed.
Right. Thank you, Dr. Saldanha, for that. And I think this point came up across all of from all our panelists, but I think we should spend some time talking about the anxiety about medication and during pregnancy, and it'll be wonderful to bust some myths on this panel and talk about what exactly the process is. And I'd like to start with Dr. Sonia, because you did while you were answering one of our previous questions, did talk about the importance of explaining how medication works and can coexist with the pregnancy, and both mother and child can be healthy. So if you can give us a little bit about what your process is and when you're talking to your patients, both the women and their families, and perhaps then we can go on to talk about what the most common myths are when it comes to this space.
Yeah, see, the decision to give medication, mostly, you have to take an informed consent, obviously, by giving the right information to the mother and the family. Now, the capacity to consent regarding medication depends upon the psychological awareness and the kind of medical knowledge they already have, the myths that they have about medications, and also what is the severity of the illness that she's suffering from. So, in the last 10 years, we've had a lot of interesting research which has shown to us that if you don't treat the mental illness, suppose you don't treat the existing depression or the severe anxiety, like Ashlesha pointed out, you're going to end up with a low birth weight baby, a preterm birth baby. And there's a lot of evidence to show how significant is the long-term impact on the infant also, if it is not treated. So if we explain these factors properly, give that knowledge correctly, and nearly 10 to 15% of women are clinically severely depressed, they suffer from depression. So in case it is mild, where the symptoms are not so prominent that they have not affected her sleep and appetite or weight to that extent and she's not suicidal, then yes, we suggest non-pharmacological interventions. If it is moderate severe, we do explain to them that what is the long-term impact if you don't treat her with medication. And then it is allowed for her and the family to make a decision whether they want to take the medication or they don't want to take the medication. What we call an informed consent based on the kind of knowledge that you participate. So here you require a lot of skill, you require figures, you require, knowledge to be given to them in an understandable manner. That, if there's a past history of suicide in her attempt in her past depressive episode, and she runs this risk of having another relapse, that's say 2-3 episodes in the past, and now she's pregnant. So we need to understand that this kind of a lady is a high risk case. So a past history, then a family history of mental illness, say a depression, and the mother also was depressed, and our client is also depressed. This genetic loading makes her a high risk case. So it's so important to liaison with the obstetrician as well as the patient family to explain them the risk benefit ratio, so that they arrive at a right decision. So I think this knowledge sharing is so important. An obstetrician has a different set of challenges to face with the patient, because the obstetrician is the first person in contact. And they would obviously be worried that there should be no medical legal issues. Suppose the child is born with congenital anomalies, and she's put the thing that she was on this psychotropic medication. But if the psychiatrist is liaising and explaining that the risk is not that high, the previous research was quite flawed. Previous research had shown to us that giving psychotropic medications increases the risk of congenital anomalies, or these are very highly teratogenic drugs. But luckily, what we have now understood, that research was quite flawed. It did not understand, or it did not go through studying the confounding factors that the maternal illness itself was contributing. And even if this risk of teratogenicity was there, it is much less compared to what it was thought to be. So, the drugs are much safer. What is understood now by the current research, that they are much safer. Of course, there are certain medications which you just cannot prescribe. Like say mood stabilizers like valproate. We all have to be aware that as obstetricians and as psychiatrists, if we don't use this molecule in the reproductive women as much as we used to do it earlier, that used to have to avoid it certainly in pregnancy. So we have to be aware of these teratogenic drugs, and ones which are not teratogenic, they are much safer. So if you give this information and you reassure, many a times a patient family agrees to a decision much more happily, to continue the medication. In fact, I have a lot of patients now telling, ma'am, the last episode was bad. We can't afford to have a second relapse in her. Please do continue the medication, and please do advise us how much should we give. So as a treating psychiatrist, we try the lowest effective minimal dose as much as possible. And we advise our patients who have suffered previously that please plan your pregnancy as much as you can. And as psychiatrists, like Prabha had also mentioned that most of the pregnancies are unplanned even then. So in those cases, we don't advise the patients to abruptly stop the medication. So a good teamwork with the obstetrician, the patient, and the psychiatrist is the key to the solution, to arrive at a good decision.
Dr. Prabha, if you could come in on that and give us your views on that.
Yeah, I think a lot of things that Sonia has mentioned is really true. That rational use of medication. I would recommend most women who have problems in the past should basically come in to meet the obstetrician as well as a psychiatrist to check what medications they can take, which are safe, what dose they should take. Also think that the moment. So what I do is I always look at the woman's pregnancy as a 9-month process, and in fact even earlier than that. So so sometimes people think that they should stop the medicine even when they're in the 5th month, 6th month. Now each medicine has a different impact at different points of pregnancy. Some medicines are quite safe in the first 3 months. Some medicines may have some effect in the 5th month or the 6th month. Or later on, or when the baby is born. So I think it's very important for that kind of collaboration to be there. More and more we know that there are many medicines which are safe. I always tell my moms that, no medicine is like 100% safe. No pregnancy is 100% safe. There's so many things we are taking in from the environment also. I like to use medicines that we know enough about. And there are medicines which we will definitely avoid. So I think trusting your psychiatrist and trusting your obstetrician to do the best for you, and giving all the information out there to the mothers in a way that they understand. also getting fathers involved in this whole process. I think just the couple needs to take that decision. And I found that if you do that in a proper manner, in a manner that they understand, pictorially, giving them examples, because sometimes it's very hard to know what is, what is 5 in 100? What does that really mean? Does it mean 100 babies or 100 people who use the medicine? So I think simplifying information and giving the right information and allowing them to ask more and more questions. Sometimes what happens is that we are going rambling away. It's a one-sided conversation. Making sure that you're addressing all their questions becomes equally important.
Thank you so much, Dr. Prabha. Dr. Uma, you have something to say.
Yeah, no, I completely agree with everything that has been said. I just wanted to reiterate that as for women with any kind of medical problems who are on medication, it's all the more important that this pregnancy is not unplanned, because then they are, they're going into it prepared. All this conversation has already happened, and we are not having this conversation when they are coming to terms with the fact that they are pregnant. The only other point that, I've personally faced in a couple of situations is that there is conflict between what this woman who's having a significant mental health issue and is pregnant and finds herself pregnant and is on medication wants, compared to what the family wants. Because somewhere there is a lot of pressure that if she has a baby, then she has met her role or the need, and the family is happy. But I've had situations where the girl has said to me, "Doctor, I don't want this pregnancy because I know what medication I'm taking. I know how much of a struggle I've had to get to this normalcy, and I am not mentally prepared for this stress." And that, while on paper, all we need is the woman's request for termination, it actually is a difficult social conversation to have and maneuver. And I think that is an even more important reason why pregnancy shouldn't be unplanned. And unfortunately, we can't give very reliable contraceptives like the pills for a lot of these women. And, so they are sometimes left without effective contraception and find themselves in this situation where they don't want to be. So that's just to highlight there is also that situation that sometimes we are faced with. And maybe Prabha or Ashlesha or Dr. Sonia can say how do we negotiate that?
Sure. Dr. Ashlesha, I think, wants to come in.
Yes, thank you. I think just leading on to the Dr. Uma's question, and also what Dr. Prabha and Dr. Sonia were mentioning in terms of the side effects of medication. I think we need to include in our conversation what we've been talking about all along is the side effects of illness, and that is what we really need to be thinking of. That if we stay ill, if the woman is ill, if she is not taking her medications, if she is stressed, if she's forced into a pregnancy she doesn't want, what will be the impact of that on the baby? I think that is our conversation. It's very important to include the families. We cannot sort of, say that, okay, the woman, I'm going to treat only the woman. And I think you're so right, Dr. Uma, that we need to think of how can we engage the families? How do we move past this problem for the mother? And so for me, I think it's really important for us to think that giving them the information about the medications, of course, but also telling them that if you don't do anything, then it's also not okay. You may have to think about the side effects of the illness and balance it out with the medications that we know to be safe. So that is what I wanted to add to that. I also want to just say that in terms of the COVID conversation that was going on earlier, the reason why even pregnancy itself, one of the difficulties that we encounter or we are facing or the women are facing is because it's an uncertain time. As much as we are trying to control, manage, reduce the risks, do the best we can in offering our help, it is uncertain. And I think that can generate a lot of difficulties. And that is why even the COVID situation right now, we don't know enough. A lot of things are uncertain. And especially with pregnancy, it's very uncertain. So from a mental health point of view, I feel like for mental health professionals, we may not have the answers. We don't know whether this pregnancy that they're taking on right now is going to have negative impacts later. But what can we do to reduce their distress when they're faced with an uncertainty? It's uncertain, there are no answers, and that is causing distress. How can you cope with this uncertainty? How do you manage your distress during these uncertain times is the best we can do right now.
Thank you so much, Dr. Ashlesha. And as you rightly pointed out, and that was the the intent with which we started to have this panel discussion, is to say that let's not just look at emotional and mental health from the perspective of just the mother, who is very important and very key in this situation, but also look at the impact that this an illness or just emotional distress can have on the baby. With that, I'd like to invite closing comments from our panel, and just go with all of our experts and see if they'd like to add anything to this very, very rich conversation that we've had this afternoon. We'll perhaps start with Dr. Sonia. Any comments that you'd like to add to this discussion?
So, I think it's a teamwork that you require for mental health issues during pregnancy. So a good teamwork includes the lowest worker, the Anganwadi worker, the midwife, the obstetrician, and the psychiatrist. So we have to collaborate and share information. Lack of education regarding mental health issues is a very primary concern to all of us. Perinatal mental care pathways are non-existent in India, in most parts of our country. Cities like Bangalore and Delhi, and they're doing much better. But every state has to develop a pathway. So we need to educate our health workers at all levels regarding mental health issues, and what is if you don't treat, the risk of suicide, the risk of the long-term impact on the health, both the mental and the physical, not just of the mother, but also of the infant. The long-term impact is very severe. So what ma'am had pointed out, Prabha, that, it's the mother-infant care. So we need to share knowledge. We need to reduce the stigma, and we need to develop this awareness, like kind of programs that we are trying to do, collaborating with you, giving information. I think that would help a great deal.
Dr. Shaibya Saldanha?
So I think building up the confidence of women, and that I think starts from school and colleges. We need to start from the education system on concept of reproductive health and reproductive rights. I think we have to reinforce reproductive rights even in rural places where the children will probably leave by 10th or 12th. Having this brought into the system, reproductive rights for boys and girls. Sometimes we keep thinking we have to keep targeting the girls. I think it's very important to target boys also, to understand that you don't say yes to marrying a girl under 18 or stopping a girl's education just because you're going to marry her.
Right. Absolutely. Thank you, Dr. Saldanha. And Dr. Uma, if you have any closing comments.
I think, two areas that we need to do a lot of work on, and which work has started and we need to focus. One is overall identifying, the areas of prevention of problems. So to enhance screening and ensure that we are able to pick up problems, and to capacity build among healthcare professionals, the ability to, and increase the ability to handle this issue. Because clearly it's a large, with our population and with the variety of segments with which women are accessing care, culturally across the country, there are so many differences. So we still need to figure out how we are going to build capacity to do this. And I think those will be our two large areas of focus that we should have.
Ways to help women, and for men also to think that just because I need mental health help doesn't mean I have to see a psychiatrist. And for us also to think that just because I'm not able to help the woman, she doesn't want to see me, doesn't mean that she can't be helped. So we all should be able to try and find different ways. There are different ways in helping the women. There are different healthcare professionals, and to work together to recognize that there are different ways in which we can reduce the emotional distress during this time.
And of course, Dr. Prabha, if you have any closing comments.
Yeah, to me, I think I'm really delighted by today's conversation, because I can see that, all of us are not just psychiatrists or perinatal psychiatrists, but all of us are advocates for our mothers and families who are having small children and decided to have babies or decided not to have babies. So I think the fact that more advocacy in this area is very important. Advocacy to the government, advocacy to obstetric societies, to make sure that this becomes part of mainstreaming, not adapting what is available in the West, screening models, pathways, but looking at what is applicable to our country and to each region in our country, because the needs are very different. I would also like to see a strong consumer movement. In Australia, in the UK, there's a very strong movement from mothers themselves, from women themselves who've gone through illness, who've gone through problems, and who want to advocate for other people. And every panel has an expert by experience. Every research study has an expert by experience. And that's how I would like the future of perinatal mental health to be in India.
Absolutely. And I think that's just a really fantastic note to end this summit on the emotional health of mothers is, because a very, very important part of what of the information that we put out also comes in from the perspective of how persons with experience tell their stories, because the clinical part of it is just one part of the story. How you experience it and how experts work with these emotions is a whole different part of the story. I'd like to, before we end, I'd like to tell our viewers that if you have any additional questions for our experts, please feel free to either place it in the chat forum, or if you'd like to be anonymous, you can also DM us, and we'll try our best to get your questions answered. We also have an ebook on maternal mental health that has been pasted repeatedly in the chat forum. It's very, very informative. It has a checklist of questions that you can go to your obstetrician with, questions that you can go to your psychiatrist with, tips that you can talk to your family about, how you can build a support system around you. So it's got the A to Z of everything that you might want to know if you're planning a baby in the course of your pregnancy or post. So please do download it. It's free of cost. It's available on the Swan Foundation website. We do these webinars as frequently as possible. At the moment, we're doing one every week. So please do follow our social media accounts, or sign up to our newsletter, and you'll know that you'll know what we're talking about. Very soon we'll have one especially for health workers and medical students, so please watch out for that one. And with that, I think I'd like to thank all our experts who are on this panel. Thank you very much. This was a really very rich discussion, and I know that we all have many more things to talk about, but we'll have to take that offline. And special thanks to Ashika, who came and told us her story, and I think that added immensely to how informative this discussion was for all of us. Thank you so much.